and welcome to our third and final learning session for the Hereditary Breast Cancer Quality Improvement Project. So this again is one of the 3 required trainings that you need to participate in if you expect to get the credit, which I'll mention in just a minute. It is the final of the 3 trainings we're doing through this project. I just want to make another acknowledgement about our sponsors. We are working very closely with the National Association of Chronic Disease Directors on this project and have been for about 1.5 years. And they are funded through the Centers for Disease Control and Prevention. And those resources are helping support our activity on hereditary breast cancer. So we thank them very much, both the CDC and the NACDD. Just want to remind everyone that this project is approved for credit. The AFP has reviewed the project and has awarded it up to 20 performance improvement AAFP prescribed credits and CME credits. You do need to participate in all the activities, and Kathy Fredericks will be making sure you all do that so that you don't miss out on getting that credit. Just want to make another little plug and thank you to our advisory committee. We have Susanna Evans from Drexel, Tracy Conti from UPMC, and I'll be introducing her in a little bit more detail tonight because she'll be speaking. Philip Day, who is at UMass. And then our staff for the project is myself, Rebecca Book, who's a consultant working with the FMEC, Kathy Fredericks, who's also our QI consultant. And I also just want to mention Anya Karavanov, who is with the National Association of Chronic Disease Directors, who's been a really invaluable help to us to learn more about Bring Your Brave, figure out what we can do with family medicine to improve hereditary breast cancer screening and referral, and really integrate the work that she's been doing and the CDC's been doing into our project. Just want to mention that our speakers tonight, who are listed on the screen, have no financial relationships to disclose. And then just review, before we jump into the content for tonight, the objectives for both the project and for tonight's session. So we're really hoping that the 8 clinics who are engaged with us in this project will learn more about QI basics and understand the model for improvement. I know many of you have had training in that and you've done other projects, but we're certainly trying to make sure through this project you stay up to speed on that. Understand the risk and incidence of breast and ovarian cancers in young women. Use a breast cancer screening tool in practice, which some of you are and some of you aren't, but hopefully by the end of this project, your team and your clinic will be very familiar in using those tools. Identify the benefits of using narrative medicine, stories, videos during patient visits, and we're providing you with tools through the Bring Your Brave campaign for that. Learn how to talk about cancer risk with patients, how to talk about where they are, what their experiences, what their journey might be, depending on their results, and gain more confidence and more strategies to do that. We know from our first cohort of this project that just wrapped up earlier in 2023 that they really felt more confident having these discussions after using the Bring Your Brave materials and working with us on these trainings. Increase knowledge of genetic counseling and testing and how to make those referrals, and then use those patient education resources from the Bring Your Brave material, however works best in your clinic, to get them into patients' hands. Tonight, we're specifically going to talk more about the QI pilot project structure and timeline. We've sort of laid the groundwork through our 3 trainings up till now to talk about hereditary breast cancer and narrative medicine. And now we're going to talk a little bit more about what we hope you'll be doing in your clinics. We're going to go over the key clinical activities that we're expecting you to address, talk a little bit about data collection requirements, including the timing of when we collect that data, talk a little bit more about using those educational resources, how you can help patients access them, and really engaging with patients as partners in care. And with that, I'm going to turn it over to our next speaker, who is Dr. Tracy Conti. Dr. Conti is chair of the Department of Family Medicine at the University of Pittsburgh School of Medicine and UPMC. She previously served several roles in the department, including vice chair for education and practice integration, and most recently, executive vice chair. She's a graduate of Temple University School of Medicine and completed her family medicine residency at the University of Maryland, where she served as chief resident. And she is also a member of the FMEC Board of Trustees for a few years now, just started a new term. So we're really grateful to Dr. Conti for leading the FMEC. And with that, I will turn it over to Tracy.
Thank you so much, Scott, and thank you all for coming here. Again, I met you at the first training session, but I wanted to just to give you an insight of, my story and why this project is important to me. So Just like Dr. Evans, I am also a survivor of breast cancer and had the benefits of having that breast cancer discovered early. And so I was not the typical patient because I'm a mom of 7. And so essentially pretty much from my physician standpoint had a low risk of breast cancer. However, I had a significant family history. I had an aunt that had breast cancer as well as a grandmother. Both of them were on the paternal side, but then because of that was not deemed to be high risk and so did not was not entered into any of the early screening programs. And so when I was 42, I was going for my regular mammogram and they found an abnormality. And it was after that that I had to do genetic screening. And while all of that was negative, some of my anxiety could have been relieved if I would have been screened appropriately because of my high risk, even though I had some protective factors. And so it's my goal for, as family physicians that we understand screening and that we can make sure that our patients that are at risk are screened appropriately so that they can get the help needed. And so this QI pilot project is really organized into kind of 4 main areas, right? One of them is, how do we identify and implement a hereditary breast cancer risk assessment screen in our practices? What are the appropriate things that we can do to make sure that this is a part of our practice and not just a one-off? How do we utilize the Bring Your Brave campaign and the CDC education resources with our patients? What's the most appropriate thing that we can do? How do we refer our patients who do screen positive, who are in that high risk category for hereditary breast cancer, to get them to genetic counseling or testing? And then what is our follow-up to really encourage our patients that they have that ongoing cancer prevention and early detection of care? So the project is set up in kind of 3 ways, and you guys have done a lot of this. You had your welcome and your orientation to the pilot project. You've made it through. This is your 3rd training webinar, and I know that some of you will watch this later, and so it will be your 3rd webinar. And so the next step is really, each team needs to select the tool that that is most useful for them to really implement the HBC screenings and to assess our patients for breast cancer. And we'll talk about some of those screenings. And it really depends on, what's easy for you, what your EHR has, or what's the best method. Not every program is going to look the same. And so thinking about and working with your QI mentor about what the tool is best for you. We are going to, again, utilize the CDC's Bring Your Brave education resources with our patients and integrating that into the educational things that we give our patients. One of the key structures of the project is that everyone has to participate in data collection. And so we're going to do a baseline study as well as you're going to do 2 QA. So the PDSA cycles, plan, do, study, act. And though each of those are going to be 7 weeks. So you'll do your baseline, and then you'll have a PDSA cycle. That'll be 7 weeks apart, and then another PDSA cycle. Our goal is for you to learn from that QI data to really make practice improvements. And so again, the PDSA cycle is on a continuum. And when you do the plan, do, study, act, you don't just end at the act. It actually flows back into the plan. And so once you see your results, how do you move from there and continue to get better? Every program does get a stipend to participate in this program. And there's also incentives, like we can supply your office with iPads or tablets to make sure that the screening is easy to implement. So we've shown this slide before, and we are really excited to have these 8 programs. You guys have this list. This is really helpful for you. So you utilize each other to be resources, but also this list, who your assigned QI coaches. I know that the 2 programs that I am a QI coach have already reached out to me and they're excited. And so if you have not touched base with your QI coach, make sure you make an effort to do that in the near future, because we're already starting in that implementation stage. Next is, some of the just more detail about the programs that we have here. Just so you know, this is just a snapshot of some of the information. We have 3 rural sites, we have 3 urban inner city sites, and we have 1 urban that's not an inner city and 1 small town. There's a variety of ranges that we talked about this before, that of the 8 family medicine residency programs represented, we have the smaller end at 12 to the larger end at 44. We'll go through this later and show you the EMRs, but there are multiple EHRs. I think there's only 1 Epic that is the same with 2 programs, but just so everybody's aware, even if you have Epic, there are different instances of Epic. And so that 1 program who has Epic, it could work a little bit different than another program that has Epic. Of note, there are 2 programs that have let us know that they have a coordinator to help support cancer screenings. And there are also 2 programs that are either using My Gene History or the breast health questionnaire already as they look at their data. And this is that second page of the program. And just so you guys know, and you guys have this information as well. And so this is just, some of the questions that we've asked you in the demographic of, how familiar were you as a program with the Bring Your Brave campaign? Of the 8, the majority of you were not familiar at all. And so just by you participating, we've already increased this, because you have seen the Bring Your Brave campaign, and it gives you some familiarity of that. The second question was, how familiar do you think clinicians with your program are with the Bring Your Brave campaign? And so that was even higher. 6 of the 8, they did not feel like their clinicians knew what was going on. And so you guys will get the slide set, and there is a link so that you can learn about Bring Your Brave and use the CDC resources with your QI effort. This is really important from an educational standpoint to ensure that we're giving the right information to our patients, and the CDC is a reliable resource for us. This is some more demographic questions that we had. Do you have a source for accessing genetic counselors? Most of you were able to access genetic counselors, so 6 of the 8. And then 7 of you had the ability to make referrals for genetic testing. So you do have the resources available for you to get your patients to the genetic counselors when needed. Again, making sure that you really do connect your patients to the CDC website, and to get them familiar with what's available, and get your providers to know what's available. These are the different sources that people have utilized in order to make some of those genetic referrals. Again, we talked about, the electronic health records, and there are a variety, and it's amazing that there are 8 programs, and there are 7 different EHRs. And again, even though there are 7 different EHRs, I can almost guarantee you that those two epics aren't the same, and different people have different instances of epic. And so, when it comes to thinking about the screening tool, you want to think about, what's already in your EMR that you can utilize. I would reach out to your IT analyst or your data analyst to think about an easy way for you to implement and create a way to get the information and to document the information so that you're not doing it all by hand and that it's sustainable. We know that anytime that there's a process improvement, if you have to do extra work to do that process improvement, often once the initial wave or the initial introduction of that QI project is done, people abandon it. But if you make it so that it's embedded into the EHR and there's prompts or there's something that's easy access or some type of a smart text, a reminder, people are more willing to do it, and you can get a longevity in the QI process. And so if you have not already, again, reached out to your IT folks at your institution, I would make sure that you do that in the next day or so. So today's Thursday, I would do it either tomorrow or Monday, so that you can get moving and figure out what's already there. And if there's nothing there, can something be easily attached, or can you create some type of drop down box that can be either a dot phrase or whatever your EHR uses to embed different material into the note, and so that it's easily tracked, easily documented, and that you can get it back. So these are some of the reasons for participating in a QI project, and I hope that you guys have thought about this. One, it's for the provider, right? We want to make sure that all the providers, especially at residency programs, are obtaining the knowledge that we need to take care of patients. And with that, there's actually patient benefit, and our patients benefit from increasing our processes in the outpatient setting. We know that when we implement the HBC screen and give residents that information and allow them to do this, it does improve patient care and patient outcomes. We need to make sure that we really improve how we screen our patients, especially in face of the changing recommendations that are occurring around breast cancer screening. This really does help us do what we want to do. Our goal is to prevent illness from happening, and we can use these preventive these screenings to detect disease early or prevent disease, to make sure that our patients are really having the best outcome and the best care. And doing the screening offers in itself, an opportunity for education. And anytime we can educate our patients and have them be invested in their care, we can really get them to understand the risks of breast cancer. And oftentimes that doesn't just stop with them. They can talk to family members, they can talk to friends and family. And so that understanding just is distributed amongst the community. We want to make sure that, the residents are interested in this work, that, that they know who needs to be screened and who should be referred, and when it's appropriate to make a genetic referral. And also we want to make sure that we're increasing our awareness of hereditary breast cancer, and making sure that we're giving the information to assist with that early treatment and decision making. And so, this is an example. Somebody has said we started to roll out a hereditary cancer assessment at the community health center. And it was difficult to get clinicians and leadership on board. And so you need to make sure that your group gets buy-in to make sure that you have support in creating those workflows. And it's not just the physicians, you really need to involve staff, clinicians, leadership, and make sure that the workflows that you developed are easy. Again, the harder you make it, the more steps there are, the less times people are going to implement that screening. And the education piece of it really does try to convince the staff, the providers, that this is important and all of our patients need to be offered this. And then the last reason is really to, help and identify patients at risk for breast cancer, and especially those that are high risk. We want to make sure we're increasing screening in our communities, and that should be patient-driven and it should be physician-driven. We discussed this in the first session. We are not pursuing a global IRB. And so if you are thinking about creating a project that you want to publish, or there are some organizations that require you to have local IRB to submit posters, make sure you think about applying to your local IRB. And, think about, is this a full IRB? Most of the time, because it's educational based and it's a screening that already exists, you can get this from an exempt status if you have a IRB. There are some institutions, however, that have quality improvement boards that oversee all the QI projects. And so perhaps this is not your IRB, but you need to take this to your quality improvement committee to get approval. As residency programs, you all work with QI. It's a part of what we do already. And so whatever methods you have for approval, you can seek that same methodology for this project. And then, as you know, that there are incentives to participate in this pilot. I know sometimes for the residents, it doesn't have much meaning, but especially for the faculty, those family medicine performance improvement credits for the MOC is something that you can do. And it's also free CME. From the ACGME point of view, and for the programs, this does meet your learning collaborative recommendations that are in the new ACGME guidelines. As we talked about before with those incentives, you're eligible as an office to get either a computer tablet or an iPad. We'll provide up to $800 towards that cost. And that's really to help you in getting those CDC Bring Your Brave resources and allowing those patients to watch those videos in real time. Again, we talked about the QI coaches. You guys have access to those coaches to help support you. So you have somebody that you can bounce ideas off of, or if you have questions, in addition to our other staff like Kathy or Rebecca or Scott. Every residency program does get that stipend to help with either conferences or registration fees. And our goal is to make sure that you guys are able to present a poster or a session of your QI efforts. Again, all of the QI coaches are available to help you and give you advice on how to prepare those posters. And if you need assistance in connecting to genetic counseling and testing support, we are able to help you with that. And also lastly is that you do get that national recognition for participating in a QI activity. So I am going to turn it over to my colleague, Kathy.
Well, thank you, Dr. Conti, very much for that. And I appreciate that you shared your story of your family's relationship and what you've gone through with regards to breast cancer in your own family. And I really appreciate that you talked a little bit about the EHRs in getting people to start thinking through like what tool they're going to select and what they can do within their own EHR or EMR to make it easy for the sites to implement this. So right now I'm wiggling my mouse. I'm trying to see if I get my slides to advance. Give me a minute here. I'm still working on it. So I have control, but it's not advancing. I'm going to talk about the timeline and then I'll try again. We began recruitment in November and December of 2023. We're really excited that we were able to, we had said we were going to try to recruit 4 to 8 family medicine residency programs or family physician practices. And we ended up having about 12 groups that came to us that were interested. And then of the 12, 8 went through the whole process and actually completed participation agreements. So we're really excited to be working with all 8 of these sites. And now we're already into February. It's already February 1st. So today's the 3rd training. And we've had a lot of people participate in the live trainings and even more are doing the recordings. And so we appreciate that. So we should have like a robust group going along in this cohort learning from each other. Again, we're going to talk in the next few slides about the data collection. So that's starting next week. We'll be gathering the baseline data. And then we're going to start our first QI action period in February and into March. And that's going to last for 7 weeks. And then the clinics will be reporting back their data collection to us at baseline, cycle 1 and cycle 2. And they'll send everything back to me, for example, as a QI consultant. And we'll look at the data reports as they come through, and then I'll be pushing reports back out to everybody so we could see like where everybody was at baseline. And then we'll look at data for cycle 1, PDSA cycle, and PDSA cycle 2. Again, we're going to learn from each other. So the second action period will be happening in April and May. And then in May of 2024, let me just say, for questions, go ahead and type them in the chat box. We will be taking questions at the end, and we will get to your question. Also, just so you know, the slides will be sent out. We'll be sending out the slide deck most likely tomorrow, along with the recording itself. And so the second action period will be ending in May, and then we'll push that information out. And then in June, we'll try to get the QI leaders together to kind of discuss what we did and how it went. I will also try to get the QI leaders together at midpoint, so that would be around March sometime, and I'll send out a doodle poll to see if the QI leaders want to get together and talk about our progress. And it'll just be a short meeting, and we'll find a date that works for everybody. And then in the end of June, we'll be doing a final report, and we'll be doing all the admin to close out, to do the attestations for meaningful participation in the project. And then the FMEC will be reporting back to the American Academy of Family Physicians, who is the group that we went to get our FMEC credits approved, so that all of the participants will get their credits. Okay, so Rebecca, I'm trying to advance and it's not working. I don't know if you can give me, okay, here we go. Now, let's see, I'm going to back up. Okay, here we go. Okay, now I'm able to advance myself, so thank you very much. Okay, so we're already, as Dr. Conti mentioned, we're already starting into the implementation. So as of today, you know, the 3 trainings are out there. Fortunately for this cohort, we've already identified a practice champion from each of the 8 family physician programs, residency programs. And I've been in communication with many of you. We talked about a local IRB, and then I'm assuming you're already working towards developing your QI team. And we're going to talk in a minute about the data collection. So you want to decide who on your team is going to be responsible for doing the data pull. And then I would encourage you, as you're going through this process, as you get to know some patients that are going to be identified as high risk or have already been identified with breast cancer, or who are going to go through being screened and identified and referred for counseling and testing, and who knows, maybe some are positive for BRCA genes, to include some of those people as a resource on your team and within your practice. Then you could even use them to connect with other patients that will be going through this experience. So there's some peer-to-peer support amongst your patient panel. And then be sure to share what you're doing with your teams, the educational resources, as well as what, you know, your aim statements are specifically to what you're trying to accomplish within your program. And then you want to provide feedback back to your team and to your clinic staff on the progress you're making within the QI project. Okay, so as you develop your process to achieve your aim station and your goals, think about the fact that, as Dr. Conti mentioned, you're going to be developing a clinic-wide policy and process to support you in doing the HBC screenings in practice. You're going to identify an HBC screening tool. And during the first training, I sent out a resource that had a list of some of the tools. And so I'm hoping the QI leaders have begun to go through that and start thinking through what tool would be best to use within your own practice. And then the next step is to figure out how to operationalize it. And then, so there's some certain things you're going to have to decide once you've determined what tool and questionnaire you're going to use. How is it going to be administered? Who's going to be responsible for scoring it if it needs to be scored? How are you going to attach it to the patient's medical record and document that the screening was done? And then how are you going to be able to document that if the screening was positive, that the results were discussed with the patient? And then I'm just reminding you that we did the QI basics training last week. So again, remember the model for improvement. Be always thinking about what you're trying to accomplish, how we know that a change is an improvement, and what change can you make that will result in an improvement. And Dr. Conti talked very well about how, you know, just because you get to the act and you've actually done something, that doesn't mean you're done. That means you're going to study the results and you're going to develop the next iteration that you're going to do to continue to improve until you get to the point where you've accomplished your goal and you can move on to your next goal. So remember, when you're doing your PDSA cycles, you want to repeat your attempts. You want to do them regularly. They can be very short and small tests of change. You can do something within a half day and test out, like if you're going to administer a questionnaire in the waiting room, you can test out who's going to do it. Is it going to be the MA? Is it going to be the front office staff? Is it going to be your medical support assistant? You know, somebody has to be designated to do that and to make sure that it's done for every patient that is going to be included in whatever policy you're going to be implementing for your practice in conducting the hereditary breast cancer screenings. And then you want to communicate frequently with your staff so they can follow along. And then you want to learn from your successes and failures and recognize your team efforts. So now when we get into data collection and the project flow, as we mentioned, we're starting next week. We'll be starting to ask you to pull your baseline data. And then, so you're going to, there's some data collection instructions that just today I sent out to the QI leaders. And there's an Excel template that we're going to use to input the data, and it's pretty simple. And we'll talk about that in a minute. And then once the data is put into this Excel spreadsheet, the QA leaders will send it back to me, and I will work with the FMEC staff and the PAC, and we'll look at what's been reported back to us, and we'll prepare a report that we can push back out to the cohort that's doing the collaborative with us, and so we can all learn together. And then once you've sent us your baseline data, at the same time, that will be informative because it will help you to determine what QI strategies you want to try and test out to implement in the early stages of this project. And remember, like, there's only 14 weeks where we're going to be able to be working with you, and it's not a lot of time. It's a very small amount of time, actually, but it should be enough time to get all the clinics or all the programs to at least identify a tool and figure out how to implement it, and then start measuring how they're doing with implementation. And so I already mentioned I'm going to be doing a doodle poll to see if we could get the QI leaders together at midpoint and then at the end of the project. And then we'll be doing the attestations in July. So the overall QI pilot project aim statements are as follows. By July of 2024, the project aims to increase by 50% the number of family physicians from these participating programs who are screening for HBC and documenting findings in the patient records. And then by July of 2024, the project aims to offer 90% of patients who meet the inclusion criteria, and we'll talk about that in a minute, who screen positive for HBC as being, you know, at risk or high risk. And it's up to you to develop your own thresholds for how you're going to implement this in your practice. So if there is a patient identified as at risk, you can give them resources. So that's why we've been asked to work with the National Association of Chronic Disease Directors. They have a big grant from the CDC, and we're implementing this QI project on their behalf in order to help share the excellent Bring Your Brave resources for patients and providers. So, and then from there, you will also be thinking about whether or not you need to provide a referral for genetic counseling or testing for patients. So the way we set this project up is because we're talking about hereditary breast cancer, and because the Bring Your Brave campaign focuses on young women, the patient inclusion criteria is to identify female patients within your practice between the ages of 18 to 44 years who have come in who are scheduled to come in for an annual physical. And you can decide if you want to go beyond an annual physical or a well child, or not a well child, like a well woman visit. Like if within your clinic, you're also doing GYN visits, and you think that is an area where you would also want to do HBC screening on a regular basis, you could consider adding that. But if you do add that, then make that part of your own aim statement, and part of like what your process and your policy is for implementation. But that's the patient inclusion criteria for the overall project. But we do also want to point out that we don't want you to omit discussing HBC cancer risk with male patients of the same age. Although for this QI effort, we won't be asking you to pull data on male patients. I know, for example, like Lawrence Family Residency Program is doing some of this already. And they feel very strongly that they, through their process, that they also want to look at male patients. So we don't want to tell you not to do that. If you're doing it and you are already doing it, continue to do that. But in terms of this project and for the data poll, we're going to focus on this patient inclusion criteria. So the target improvement goals are, by the end of the effort, the goals for the participating clinics or the FMRP programs who see patients that meet the inclusion criteria are as follows. 50% of the patients will have documented in the patient record that an HBC screening has been completed in the past 12 months. And then of those, if an HBC screen is positive, 50% of the screenings are documented in the patient record as having been discussed with the patient. And if the screening is positive, 90% of the patients have been offered or provided with the CDC Bring Your Brave patient education resources. And then of the screening was positive. 90% of patients have been referred for genetic counseling or testing, if that's warranted. So this is another way of restating those goals. And so I wrote them out in a way that I'm more familiar with reading and discussing, and that's talking about key clinical activities. So when we're doing the data collection, we're going to actually ask you to respond to these questions. And so each one of these 4 KCAs, like the KCA 1, it's talking about, has the screening been done and documented in the patient record? So remember, you're going to pull 10 records, and we'll talk about how you're going to do the pull of data. But that's going to be a yes or no answer. And then of those that are screening positive, we're going to be asking you to ask us or to tell us if you discuss the result with the patient, if the result is positive. And then, so that's a yes or no answer. And if the screening wasn't done for some reason, then you would just put an A. And it's going to take you a while to be able to set this up and start implementing it in practice. So for the groups that are not even doing this at all right now, when you're answering these questions for baseline, pretty much all the answers will be mostly no. So, but then by the first PDSA cycle, so you're going to have 7 weeks where you're going to work on it. You're going to start to implement it. You're going to identify your tool, and you're going to start to, operationalize it. Talk to your staff about what you're doing it, why you're doing it, the who, what, when, where, why. So then you should start to see a boost. But then we're saying that by the end of the project, we're hoping that you can achieve these target goals. And it's good to point out that, like, of the 10 records that you pull, you may only have 1, for example, that comes up as being positive for high risk. And so that would be a patient that then you would want to continue to follow on with, because you would want to, then we're going to have you drill down. Did you do your CD? Did you introduce the Bring Your Brave resources? And did you talk to the patient about the genetic counseling and the testing? Okay, I'm trying to advance. Oh, it's not advancing. I'll try again. Okay, here we go. Okay. I'm going to skip this slide. It's a slide we covered with the QI basics, but it just talks quickly about remembering what your outcomes, looking at your outcomes and your process. And then as you're implementing a process, how is it working? Is it having a positive effect or a negative effect? And also if you need to make a structural change or provide more education to your staff because they're not fully understanding why they're doing something or what they're supposed to do, then you need to deal with that early on. Again, I apologize. Okay. So here are the data collection instructions. We're asking that the participating programs pull 10 unique last seen patient records for female patients between the ages of 18 to 44 years, presenting for annual physicals at baseline and for the 2 QI cycles, 7 weeks apart. The de-identified records will be reviewed to track progress and implement to track progress in documenting in the patient record that a breast cancer screening has been administered. And of those, you're going to be, answering those questions, yes or no, about the results being discussed with the patient, the resources being provided, and whether the patient was referred for genetic counseling or testing. Good. Okay. So here is an example of the Excel data collection tool. So this is an Excel spreadsheet that we're going to use for all the programs. Each program will have their own spreadsheet. And this is just an example of like what it will look like for baseline. And then the QI leaders will be they've already received this tool. So they're going to fill out this info, they're going to do their data pull. And then I'm going to look at the instructions with you for a minute. So we're going to ask you to use this template. And then we're going to ask you to use the inclusion criteria so you know what kind of records you're going to be pulling. And we already discussed that. And then we're going to ask you to pull 10 unique last seen patient records that meet the inclusion criteria. In terms of the timing, we're gonna go over the calendar in a second, but starting next week is when you're going to begin to do your baseline pull. And then for PDSA cycles 1 and 2, we're going to ask you before you do your data pull to not start pulling the data for the last seen patients for a week. So we want to leave a week of wiggle room because we know that the physicians are going to need time to close out their patient notes. So we don't want to we want to make sure that the physicians have had time to do their patient notes so that when you're looking at somebody's record, you know that there should have been enough time to have documented in the record that the screening was done, and that if it was a positive screen, that the other 3 key clinical activities were pursued. And so now let's look at the calendar. Okay, so this is the data collection calendar. So again, today's February 1, tomorrow's February 2. So we're going to ask that next week you start thinking about your data pull for baseline. And we're going to ask that you send your data back to me by February 9th using that Excel spreadsheet. So the QI leaders will have to think about who's going to help them pull the data and how you're going to do that. If you have an IT analyst or somebody who's very familiar with your medical record, or somebody who can help you with pulling that baseline data, be sure to utilize that person. And then once you go through the steps for doing it at baseline, it'll be a lot easier to do it for 7 weeks later for PDSA cycle 1, and then 7 weeks later for PDSA cycle 2. So let's just say you're going to send your data pull back to me by February 9th. If you can't make that date, there's a little bit of wiggle room since it is baseline. And since most of you haven't even started working on this, you can assume that most of you are going to be answering no, that you haven't been doing this yet. So I don't want people to get stressed out about pulling their baseline data. But if you can get it in by February 9th or very shortly after that, that would be awesome. And then we've given ourselves a week to analyze the data from the FMEC side and then to push it back out to you so you can see how everyone's doing. And then this gives you a little bit of time then to start thinking about, okay, what am I going to do for my QI strategies and for my PDSA cycles? And then you're going to figure out what you're going to work on. Now you could have several different PDSA cycles. You could do one a day. You could do 1 a week. So you'll start out with what's the low-hanging fruit that you want to do to get you guys rolling on this, and then what else can you do to continually improve until we get to the end of the cycle. I'm trying to advance. Okay. So the pulled data will be de-identified and it will be added to the data collection tool and to the template and send it back to me. There's my email address, and you can call me on the phone if you need help. And so reach out to me and I will definitely help you. And we want it to be easy. Again, I'm trying to advance. Okay, so we have this document. It's called the Names and Barriers Grid. It comes up with a bunch of ideas for how you can make change. This is on our website. Our project webpage has a lot of materials, and so we come up with some barriers that we think you might face, and then we come up with suggested ideas for change and how you can deal with it. So hopefully this tool will help give you guys some ideas to get rolling on this. Okay, and we have a project webpage, so please visit it. A lot of these tools are out there. I will be adding more tools. I'll be adding the Excel spreadsheet and the calendar, the data calendar. And so it's in the middle of our project webpage. On the project webpage as well are the links to the recordings, the links to the slides, and I'll be sending these to everybody here probably tomorrow or by Monday as well. So you won't have to go hunt for them. So watch for that. And again, we want you to learn about the Bring and Brave resources, which we already discussed in the first training. And there's like 52 different video clips that are excellent. And so the idea would be to select 1, 2, or 3 or more of those videos, and they address a lot of different areas of hereditary breast cancer. So some address like BRCA genes, some address families that have significant risk for HBC, but don't have testing positive for the genes themselves. And then we also have some videos on male patients who are developing breast cancer. So there's a video out there for everybody. On the CDC Bring Your Brave website, there's also really good resources on genetic counseling and testing. So that's another great resource for you to use. And this was a slide that we discussed in the first training, but it's just a reminder that the BRCA-related cancer risk, it can be reduced by 90% or more through preventive options. And yet only about 10% of those with a BRCA mutation in the US are aware they carry a mutation. And that primary care is the most opportune setting to conduct a breast cancer risk assessment. And then among patients seen in primary care, less than a quarter of women at high risk of breast cancer were referred for BRCA testing 1 and 2 in accordance with the United States Preventative Services Task Force recommendation. And 3/4 of primary care physicians never referred a single patient for genetic testing. So there's a real need for this. And now I'm going to show you a video clip to just kind of tie this all together. And then from there, we're going to do some final comments and closing out. So this is a really nice, well, it's a very interesting video. It's Ashley's family history of breast cancer, finding the courage. And I just want you to kind of listen to this and watch it. It's about 2.5 minutes, and then we'll talk more.
I was 18 years old when my mother lost her life to breast cancer. At that time, I was in college and I was scared. Breast cancer has aggressively attacked 3 generations of women in my family, and I really felt like cancer was coming for me. It was only a matter of time. I had genetic testing, and that's when I found out that I was the carrier of the BRCA2 gene mutation. I knew that I had an increased risk of breast cancer. But I walked into my high-risk oncologist and I was just like, you know what? This is not for me. They've got the wrong person. And I immediately walked out. But eventually, that inner voice in me said, no, you need to go back. I realized I had not accepted my BRCA mutation. I was still grieving from losing my mother, and that I still had to continue to press forward. And so the second time I went in, I actually did see my doctor. She shared with me my different preventative options, and she was very aggressive. And I remember telling her, I really feel like you're treating me like I have cancer. I don't have cancer. And then she said something to me that really changed and shifted my perspective. She said, Ashley, I have to be aggressive. She said, because you have options. She said, your mother, she didn't have options. And so it was almost like a surrender. I just kind of threw my hands up and I just said, you know what? You're right. Let's explore those options. Eventually, I did have a preventative double mastectomy to reduce my risk of breast cancer. And, I look at it like this. Breast cancer aggressively attacked 3 generations of women in my family. And through genetic testing, we can aggressively attack breast cancer.
So that was a nice video. I mean, an interesting video, and it really brings the point home about like why we're doing this. And I really appreciate the PAC members supporting you and the project to move forward with this. I'm going to turn it over to Scott now.
Great. Thank you so much, Kathy. And thank you again to the CDC and the NACD for those great tools. If you've had a chance to look at some of them, you'll see they cover a lot of different topics. And the more familiar you are with them, the easier it'll be to recommend some of them to your patients. So there is an evaluation link in the screen, and I will put it in the chat as well for this session. We have about 2 minutes, and I just want to make sure if anybody has any questions, feel free to unmute or put it in the chat, and one of us will be able to answer that, and then we'll wrap up. So any questions?
I did see somebody wrote and asked, like, when should we start working on our first PDSA? And I would say tomorrow. Well, you know, so right away you're going to start thinking about what tool you're going to use. So please get together with your team and begin that process. Talk to your EMR, EHR person to help you figure out how you could operationalize it and try to make it easy for you. And then, as Dr. Conti said, and then I'm going to turn it over to you, Dr. Conti, to give your thoughts. But you know, you have to think about getting buy-in from your own practice leadership and from your own staff to really have a good go at this.
Yeah, the only other thing I would add is that making sure that you get your baseline data, you have to have that before you start your PDSA cycle, or if you do your education or your intervention before your baseline data, it's going to skew your results.
Good point.
Well, thank you all again so much for joining us, and thanks to your team back in the office who will watch this and the other videos remotely. But we are looking forward to getting your baseline data and getting things started and seeing what kind of strategies you employ in your clinics. I want to thank Dr. Conti and thank Kathy again for presenting, and we will all be in touch as the project moves along.